Hello everyone and welcome to our module on glaucoma. So before we talk about glaucoma, let's talk about a very important substance in the eye, and that's called aqueous humor. So this is a drawing of the eye, and most of the eye is filled with this fluid called vitreous humor, and that's what fills the posterior portion of the eye. But in the anterior portion of the eye, just in front of the iris, is something called the anterior chamber, and that has a fluid inside of it called aqueous humor. There's also a smaller area called the posterior chamber, which sits behind the iris. So in front of the lens, there is the posterior and anterior chamber, and it's divided by the iris so that the posterior chamber is behind the iris and the anterior chamber is in front of the iris. And the anterior and posterior chamber both have aqueous humor, and don't confuse that with vitreous humor, which is what's in the back of the eyeball. Your eye needs aqueous humor so you can see. It's what gives the eye its shape and it nourishes the eye. So there's a very important process by which aqueous humor is produced and then drained from the anterior chamber. So the ciliary muscle, which is the muscle responsible for accommodation or changing the shape of the lens of the eye, has an epithelium, and that's what produces aqueous humor. And this is under the influence of the sympathetic nervous system. It can stimulate the epithelium to produce more aqueous humor by beta receptors. From there, the aqueous humor gets drained from the anterior chamber through a structure called the trabecular meshwork, and from the trabecular meshwork it goes to the canal Schlemm. So here's a little drawing of that process. This is the lens of the eye right here, and this is the iris. And over here, not drawn, is the ciliary muscle. And so its epithelium is going to secrete aqueous humor into the posterior chamber right here behind the iris. The aqueous humor will then fill the posterior chamber and fill the anterior chamber, and from there it will find its way over here to this little angle between the iris and the cornea, and the trabecular meshwork is in there, and so is the canal of Schlemm, and that's how it will get drained out. And so this is the process by which aqueous humor gets produced and drained from the eye. Aqueous humor creates pressure in that anterior chamber of the eye, and you can measure the pressure in the eyeball using something called tonometry. If you've ever been to the eye doctor and they blew a puff of air into your eyeball, that's one way of measuring the pressure of the eye. There are more sophisticated ways that ophthalmologists use in treating patients with severe intraocular pressure problems. And the intraocular pressure is determined by the amount of aqueous humor. So when there's too much produced or too little drained, you can get high intraocular pressure. The autonomic nervous system has a role to play in controlling intraocular pressure through controlling the amount of aqueous humor in the anterior chamber. So the parasympathetic system, through muscarinic receptors, can constrict the ciliary muscle, and this allows fluid to drain more effectively from the eyeball, and this lowers the intraocular pressure. The sympathetic system, through beta 2 receptors, can tell the eyeball to produce more fluid. This allows the eye to focus during fight or flight. That's why it's part of the sympathetic system, but more fluid can generate more pressure. So when patients have high intraocular pressure, we call that glaucoma. And the reason it's bad is because it results in optic neuropathy. Over time, it will destroy the optic nerve and patients will go blind. And it's high yield to know that the pattern of visual loss in glaucoma is peripheral vision first, followed by central vision last. And there are two types of glaucoma, open angle and closed angle, and you need to know the difference. So let's talk about what we mean when we refer to the angle of the anterior chamber. Well, the angle is formed by the iris and the ciliary muscle and the cornea going forward. You can see that this forms an angle. And in this example on the left side of the screen, the angle is open or normal. So if a patient had this type of angle and the patient had glaucoma, we would say they have open angle glaucoma. If you look at the right side of the drawing, you can see that the iris has been smushed against the ciliary muscle and the cornea, and therefore the angle is closed. So if a patient had this type of situation and developed glaucoma, we would say that that patient has closed angle glaucoma. So closed angle glaucoma is the more rare type of glaucoma, and this occurs when the angle for drainage in the anterior chamber suddenly closes. It typically has an abrupt onset. Patients present with a painful red eye. They can complain of blurred vision with halos, and classically the eye is very firm. It's often described as being rock hard. Symptoms of closed angle glaucoma can be triggered when the pupil dilates. If we go back to this drawing, the angle is determined by the iris, and when your pupil dilates, muscles in the iris move in this direction. So you can imagine how in some situations they could potentially move in such a way that they close off the angle of the anterior chamber and cause closed angle glaucoma. This means that potential triggers for closed angle glaucoma include things like entering a dark room that will lead to pupillary dilation, or taking a drug that has a pupil dilating side effect, a drug like scopolamine or atropine. These are muscarinic blocking drugs and they can lead to dilation of the pupil. And closed angle glaucoma, in contrast to open angle glaucoma, is an ophthalmologic emergency. If the eye is not treated quickly, it can lead to permanent vision loss. Medical treatment is not very effective for closed-angle glaucoma. The definitive therapy is eye surgery. However, while the patient is awaiting eye surgery, medical therapy is often tried in order to temporarily lower the pressure and stave off some of the complications. Often multiple drugs are used. Some ophthalmologists refer to this as the kitchen sink approach of treating closed-angle glaucoma while the patient is awaiting surgery. So some of the drugs that can be used include acetazolamide. This is a carbonic anhydrase inhibitor, and the enzyme carbonic anhydrase is important for synthesis of aqueous humor. Mannitol is sometimes used. Mannitol is an osmotic diuretic that I talk about in the renal section, but it will draw fluid out of the eye and potentially lower the pressure. Timolol is a beta blocker, and pilocarpine is a muscarinic agonist, and both of these drugs can also somewhat lower the pressure in closed-angle glaucoma. There is a variant of angle closure glaucoma called chronic angle closure glaucoma, and in this situation a portion of the angle is blocked and develops scarring, and over time the angle gets progressively more closed. The pressures don't get quite as high, so there are less of those symptoms like pain and things that bring people to urgent attention. For this reason they can have a delayed presentation, and there can be more damage to the optic nerve by the time the patient finally presents to a physician. And the diagnosis is often made when peripheral vision loss occurs, because remember, peripheral vision loss occurs first before central in patients with glaucoma. So open-angle glaucoma is the far more common form, and you'll see many elderly patients on your clinical rotations taking eye drops, and that's for open-angle glaucoma. These patients have no symptoms until the eyesight occurs when they lose peripheral and then central vision, and that's why primary care doctors tell their elderly patients to go to the eye doctor, and that's why the eye doctor screens for high pressures with that puff of air in the eyeball. This occurs when there's overproduction of fluid or decreased drainage. Remember, that angle is open, so it's something inherent to the system that produces and drains the aqueous humor. The angle for drainage is open on exam. There's too much fluid or too little drainage, and these patients go on chronic drug therapy, usually chronic eye drops. Open-angle glaucoma is associated with a couple of things you should know about. The first is age. It's very uncommon in people under 60 or 50 years old, and it's much more common in the elderly. If you have a family history or if you're African American race, you're more likely to get glaucoma. Now, most patients who have glaucoma have primary glaucoma, and we don't know what the cause of that. But there are rare cases where someone gets open-angle glaucoma that's secondary. So uveitis is inflammation of the uvea, which is the choroid, the ciliary body, and the iris. And so if you've had this, it can impair the drainage of fluid. Trauma impairs the drainage of fluid. Patients who take chronic steroids have decreased drainage of fluids. The mechanism of this is not entirely clear. And then patients who've previously had a retinopathy can develop open-angle glaucoma from decreased drainage over time. You should know what disc cupping is and be able to recognize it in a picture. So when you do a fundoscopy exam on your patient and you look in the back of the eyeball, you will see the optic nerve like this. And there's this bright area in the middle, and that's called the cup. And normally it's less than half or a third of the entire radius of the optic disc. However, in patients with glaucoma, that gets much bigger. It may be almost the entire size of the optic disc, or it may be much greater than 0.5, and that's called disc cupping. So you see an increased cup to disc ratio, that's the terminology used in patients with glaucoma. There are 5 classes of drugs used to lower the intraocular pressure in chronic open-angle glaucoma, and just like for systemic hypertension, you need to know the mechanism by which all the drugs work. The first group are the muscarinic agonists. These are M3 receptor agonists, and recall that the parasympathetic system lowers intraocular pressure. So if you agonize or activate the parasympathetic system, you will lower intraocular pressure. And the mechanism by which these drugs work is to contract the ciliary muscle and increase the drainage of aqueous humor from the anterior chamber. The next 2 drugs are the alpha agonists and the beta blockers, so they block the sympathetic nervous system. And recall that the sympathetic nervous system can stimulate the ciliary epithelium to release more aqueous humor. So beta blockers directly block that effect of the sympathetic nervous system, and then alpha agonists do that indirectly. Recall that the presynaptic neuron has a alpha-2 receptor right here, and that senses norepinephrine. So when this neuron releases norepinephrine, it feeds back on this receptor, and then the receptor says, okay, we've released enough norepinephrine, and it shuts down norepinephrine production. By activating or giving an agonist to this alpha-2 receptor, you basically trick the presynaptic neuron to release less norepinephrine. And the effect is the same as for beta blockers. So both alpha-2 agonists and beta blockers will block the ciliary epithelium so it releases less aqueous humor. The next class of drugs are the prostaglandin analogs. These vasodilate the canals of Schlemm and increase the outflow of aqueous humor. And finally, carbonic anhydrase inhibitors can be used to decrease the synthesis of aqueous humor. So we'll talk about each of the classes in a little more detail. The parasympathomimetics are carbachol and pilocarpine. They are muscarinic agonists. They contract the ciliary muscle so the trabecular meshwork opens up and you get more drainage. The alpha agonists are apreconidine and brimonidine, and they are going to decrease the production of aqueous humor. A little under 15% of patients have some type of ocular side effects, so they can experience blurry vision, they can get red eyes, they can have a sensation that there's a foreign body in their eyes, or they can be itchy. Nevertheless, most patients tolerate these drugs just fine. Beta blockers are drugs like timolol and betaxolol and cartiolol, and these decrease aqueous humor production by the ciliary epithelium. The prostaglandin analogs are all drugs that end in prost, so I've written the names of some of them here, and they make more drainage of the aqueous humor occur, and this will lower the intraocular pressure. A special side effect of these drugs is that they can darken the iris, so patients need to be warned before they take them that they may see a change in the color of their eyes. This only happens to people with certain eye colors and usually isn't a big problem. And then the last drug class is acetazolamide. It's a carbonic anhydrase inhibitor. This is actually an oral drug. It's a mild diuretic, and it causes less fluid production by the ciliary epithelium. This drug isn't used very much anymore now that we have eye drops that work very well, but it was used a long time ago. And you should also know that most patients with glaucoma require more than one drug, so a lot of the patients I see are on 2 or sometimes even 3 drugs to keep their intraocular pressure down, and these drugs are titrated by an ophthalmologist. The last drug I'll discuss is epinephrine. Epinephrine eye drops were one of the first therapies for glaucoma ever used. They aren't used very much in the modern era. Epinephrine, as you may know from its hemodynamic properties, has mixed alpha and beta agonist effects. So when you administer epinephrine eye drops, the early effect on the eye is to increase aqueous humor production. This is a beta effect, and this is not helpful for the treatment of glaucoma. However, later epinephrine results in vasoconstriction of the ciliary body, and this leads to decreased production of aqueous humor over time. Therefore, on balance, this is an effective drug for lowering the intraocular pressure. Now, one special note about epinephrine, it can only be used in open-angle glaucoma. You can never use this drug in closed-angle glaucoma. That's because epinephrine will dilate the pupil, and as I discussed earlier, dilation of the pupil can cause or worsen closed-angle glaucoma. Therefore, you never want to use this drug when the angle is closed. And that concludes our video on glaucoma.